and I'm very proud to step in for these two very esteemed researchers. So this is data from the IASLC IMIG Database for staging of mesothelioma. As a medical oncologist, the two commonest questions I get asked are, should I go for radical surgery, in your opinion? And what stage am I? And patients recently diagnosed with mesothelioma are generally very well versed, and they've looked up things on the internet, as you all know. And not unsurprisingly, they know about cancer staging, and many of them know about the concept of TNM and so on. And of course, we just don't have a staging system for mesothelioma that works in the way that the TNM does for colorectal cancer, say, lung cancer, breast cancer. And the idea behind this project was to try and understand which of the descriptors for staging for mesothelioma from the current system, which is the IMIG IASLC system described by Valerie Ruch over 10 years ago, which of those descriptors work, which don't, and so on. And I'm sure many of you have sent patients to Valerie Ruch and the data team at Cancer Research and Biostatistics in Seattle, who have been collating all the data. The project continues, and I will tell you how to participate after the data. So there we go. The IMIG system actually nearly 20 years old now. There have been, of course, other systems, the famous Brigham system, the Eric Butchart system, and so on. And as you all know, these systems are largely based on surgical series. And whatever your patient practice, most patients, the majority, 50% plus, do not receive radical surgery. And so it's very hard to know what this staging system means for those folks. The T descriptors in particular are very hard to apply based on predictive axial imaging, which has always been CT until fairly recently. The N descriptors are largely based on non-small cell lung cancer, and of course mesothelioma is not non-small cell lung cancer, and that's why we're all here, because it isn't. And the stage groupings, the amalgamated TNMs, are also open for debate. So the idea was to collect as much data as possible and work out what, if anything, divides people into prognostic groups to help, obviously, for prognostication and treatment selection to some degree. So an international database has been developed. It's funny because the screen here chops off half the slides, so I can't actually see the beginning of the sentences. It was representative of the known demographics of mesothelioma-type patients, inclusive of all tumor stages and all treatments, and to perform an analysis leading to a data-driven, hopefully, revisions of the IMIG IASLC system, TNM system. And because the TNM system that we have is based largely on surgical patients, the initial phase of the project, rationally, was designed to look primarily at surgical patients, because those are the ones where we're going to have surgical confirmation of predicted clinical TNM. So that was the initial plan, to see how well pathologic staging fitted with clinical staging. This is how it was done, and as I say, CRAB is in Seattle. Data's been analyzed by the routine of Kaplan-Meier, Cox regression, and log rank. And as usual, P0.05 has been taken as the traditional statistical significance borderline. These are the patients recruited so far. Turkey's there because I think these slides were first presented in Turkey by Valerie, but that's fine. And as you can see, there's over several thousand patients now. The median age, 35% were quite young patients, and 58 over 60. The usual sort of distribution of gender and epithelioid histology, and asbestos exposure data was not complete. and was not available in about 20% of patients. It was stated as unknown in 30% and was not recorded or was uncertain in the other 20%, in case you're wondering why those two figures don't add up. So Valerie thought through the idea of three types of TNM: clinical, which we know about, pathologic, which we know about, and BEST. And BEST was a combination of P and C TNM derived from those patients who did undergo surgery. So not all the patients in the dataset did actually undergo surgery. Most did. And an estimate of BEST TNM was made by those submitting data. The stage distribution of patients submitted is as follows. So the majority in the sort of stage 3, 2, 3, 4 in BEST TNM. 65% underwent surgery with curative intent, EPD or EPP type operations, and the distribution of operations in that group, 51% of the total, 51 EPP and 12.9% pleurectomy decort. A correlation was looked for between clinical TNM and pathologic TNM. And if you see here, I don't want to take out your retina there, Hassan, so just lean back as you are doing, quite right. 65% were in stages 3 and 4, and fewer than 30% stages 1 and 2. This is interesting, and it shows how pathologic staging altered from clinical staging. And grey is upstage, so obviously the surgical findings suggested a more advanced stage than originally predicted, and this was particularly likely for stages 1 and 2. And for those surgeons in the audience, you'll be familiar with that, I'm sure. And for stages 3 and 4, upstaging was unlikely, partly because there isn't much you can go from 4, frankly, and there's a certain amount of downstaging, happily, in that group, which is always good. So it really does confirm what we all know, really, that the TNM system isn't that great, and our staging predictions are not always that great. So here's survival by T descriptor status, and this is T1, of course, in the blue, T2 in red, and T3 in green, and so on. And you'll see that the T2 and T3 are very, very close, and you'll see the statistics in a minute. N status. So patients were staged as N0 to 2, of course, and a big separation for N0, and N1 and N2 almost overlapping. Clinical overall stage amalgam, TNM overall stage, as you can see, T1, T2, T3, and T4 did separate out, obviously not nearly as much as they would in most other cancers. So this is another expression of the problem we have with our staging system. And also, I suppose, the relative ineffectiveness of much of our treatment. Okay, and this is pathologic stage. A bit more of a separation here. So these patients have undergone surgery for curative intent or palliative surgery. And there's a slightly better separation there. Here we've got histology, clinical stage, top left, pathological stage, top right, and then BEST stage, combination of the two, or BEST predicted stage by the 3 main histological subtypes. And as we would all know, epithelioid is much better, biphasic in the middle, and sarcomatoid following behind. And of course, this funny tail reflects small patient numbers undergoing surgical intervention with sarcomatoid. Okay, here's the Cox regression model data. T2 versus T1, as the Kaplan-Meier showed, was non-significantly different. T3 versus T2 was different. T4 versus T3 was also different, with convincing statistics. Amalgamated stage groupings, 2 and 1, not significantly different. So possibly that group needs to be looked at again when we hopefully revise the staging system at some point. 3 versus 2 separated out, and 4 versus 3 separated out. The N descriptors, N1 versus N2, no separation there. So you're either node positive, 0, or N1 or N2 combined. Again, so the nodal staging probably will need to be revisited. And of course, the big difference we've got now, based on different from most of these patients, is PET scanning. And we will need to build that in some way, hopefully. Non-epithelioid versus epithelioid histology, very powerful. Male versus female. Female is a better prognostic group. And age, as we all know. And palliative versus curative surgery, which I suppose is a sort of self-fulfilling prophecy, separates out nicely, hopefully, which is kind of reassuring. Here we have survival by surgical intent. So those patients whose surgical plan was to aim for macroscopic resection of all disease, curative intent, and in the red line, those who had surgical intervention for palliation only, and that separated out. Surgery for curative intent with the addition of an adjunctive therapy. And the data set did not look into detail of chemotherapy regimens, types of radiotherapy plans, or even whether the person had chemotherapy and radiotherapy in detail. But nevertheless, some kind of adjunctive therapy clearly helps you get into a better prognostic survival group. And then surgical intent and stage group. So you've got early stage curative in blue, at more advanced stage patients with curative intent, and of course some of these people would have been those who were upstaged from an early stage to a more advanced stage. And then the palliative patients is pretty much overlapping. By type of curative surgery or curative intent surgery, stage 1 and 2 treated either with EPP or pleurectomy decortication. I'll let you read through those, and as they go through, they fan through. And, you know, obviously there's a good advantage for the stage 1s having EPP in this series and PD less. So PD is sort of lost in this sort of LA freeway system of survival curves here. And stage 4 EPP, interestingly, but of course no one would do a EPP on stage 4 based on clinical predictive staging. But nevertheless, interesting and a lot of patients. Surgery by curative intent, whether or not they had 4 or more nodes, or fewer than 4 nodes, no actual statistical difference between the survival. So, to conclude, this is the largest multi-center database to date in surgically managed patients. Demographic information is consistent with what we know about published literature on the type of patients we're looking to treat. Despite this being, quote, a surgical database, the majority of patients had locally advanced disease. The analyses show inadequacies of current staging, particularly in the T1 versus T2 descriptor and the stage 1 versus 2 amalgamated stage grouping and the end staging. So expansion of this database is critically important to address these issues. We need more data. The data must ideally be international to be high quality, give us the best way to develop an international staging system. That's what their plan is. Data can be submitted to be retrospective or prospective as you wish. Data entry is now web-based for direct submission to IASLC. And we particularly want very detailed and your best possible information on T and N categories, as well as everything else. And you can email Valerie Ruche direct at her memorial website, memorial email rather. And also on the IASLC website, there's an upload and information portal. And that's it. Thank you.